welcome to today's episode of the Medical Fitness Podcast, powered by the Medical Fitness Association and the MRF Institute. My name is Jeff Young, and I'm a kinesiologist and co-founder of the Medicine, Rehab, and Fitness Institute. My co-host today will be Thomas Hammett, the Director of Operations for Pinnacle Lifestyle Medicine and the other co-founder of the Medicine, Rehab, and Fitness Institute. Hey, Thomas.
Hey everyone, and before we start, I need to take a second to thank Jeff and David, the other host of this podcast who isn't on today. They've taken the reins of the podcast over the last couple months. My wife and I just welcomed our second kiddo, a little girl, and I've taken some time away. So thanks, Jeff, and thanks for letting me bring a couple friends on the podcast today as well. We're excited to have two guests join us today. The first is Ashan Korala. Ashan is the Director of Wellness Services at Pinnacle Lifestyle Medicine. Ashan and I have worked together at Pinnacle now for the better part of a decade, and I'm excited to finally have him on the show. It's been a long time coming, man, so excited to have you here. Second is Alex Cannon, who is the lead exercise physiologist at the cardiac rehab program at Valley Medical Center. This will be the first of two episodes this month that are meant to share a few different perspectives of the medical fitness model in action through Pinnacle. So I'm really excited that Jeff and David have agreed to bring on a few of the excellent people that I work with on a day-to-day basis. So back to Alex and Ashan. I've worked closely with these guys over the past 2 years now to develop and deliver a new method of cardiac rehab that has some really unique components, and that'll be the basis of a lot of our discussion today. So thanks for joining us, guys. The first thing I want to do is give you a moment to introduce yourselves further. And Sean, do you mind kicking us off?
Yeah, of course. Thanks for having us on. I'm excited to finally be a part of this podcast and looking forward to having a good conversation. Background for me is growing up, actually, I had asthma and was and struggled with that for a long time. And I actually ended up using exercise to help overcome that. And so that ended up becoming more of a passion. That I went to Oregon State for my undergrad and graduated with my undergrad in exercise science, which then allowed me to then use some of the knowledge and skill set I had towards prescribing exercise in more of a clinical sense. And for me, it was an initial example of how I could overcome asthma, and then it's quickly became into the cardiac rehab setting, working closely with those patients as part of a program that Oregon State does with some of the local hospitals. And there I got to really see how exercise is used as medicine in a healthcare setting, which is just something you don't see too often in other places. So that was a really a cool experience that led me to this career trajectory that I've gone through. I moved to Seattle in 2012 and got a chance to be in some big box gyms, and noticed that there's just such a big discrepancy between how we prescribe exercise in more of a medical health setting and a trainer's version of prescriptive exercise, which is more of a sense of how do we keep the patient or member engaged in the training experience rather than like the exercise prescription. So I joined Pinnacle in 2015 with really the vision around creating standardized protocols for chronic disease management and how do we use exercise to actually mitigate some of the symptoms and chronic diseases that we experience in our communities. And so that's where I've been for the last 10 years now. As a director of wellness services. And so Thomas and I get to share this vision and embark on how we approach making lifestyle medicine a community known service everywhere.
It's awesome. Thanks, Sean. Really appreciate it. And before Alex introduces himself, so when I was a young physical therapist, Alex is one of the first exercise specialists that I worked with in the PT setting. Actually, he moved out after an interview with the CEO of our company, all the way from Arkansas, and took the job sight unseen and came to work alongside me in the exercise role. Alex is one of the best ESs that I ever worked alongside. So that's a good kickoff to your intro, Alex, but go for it, man.
Yeah, again, thanks for having us. I'm not too sure if I need any more introduction than that. That was pretty good. Thank you, Thomas. As you mentioned, went to school at University of Arkansas, got my bachelor's in kinesiology, my master's in exercise physiology there. And I was fortunate enough to have some professors and some experience in cardiac rehab, and really found my calling while in school. And that really paved the way for where I am today. Um, Took the position at Pinnacle as an exercise specialist working in their Lifestyle 365 program. And about a year later, Pinnacle and Valley had their merger for their Maple Valley and Covington locations, and became a Valley employee and saw an opening in cardiac rehab and jumped on it. Um, Very fortunate to have had that opportunity, knowing that cardiac rehab is what I wanted to do. So I've been in here for the past 6 years, been the lead exercise physiologist for the past 3, and have really built this program into something special. I think we're delivering a great program, and would love to see more spaces use this model.
Well, thank you guys for your intros. I really appreciate it. I alluded a little bit earlier that we were going to be talking about cardiac rehab some today. And I'd love it if we could start with the basics here, as I don't want to assume that our listeners are going to know what cardiac rehab is as in depth as we do. So maybe Ashan, if you could even start for us, just kind of give us the cardiac rehab 101, like talking about phases of cardiac rehab and who gets referred. And then Alex, if you could tell us a little bit about in the day of the life, like for you, what that looks like. So go for it, guys.
Yeah.
Absolutely.
Cardiac rehab in general, most patients who qualify for the program is anyone who's post-MI or heart attack, or having had some sort of procedure that was done to their heart, whether it's a bypass surgery or valve repair. Most of those cases are sort of direct to cardiac rehab programs. An area that we're trying to grow that doesn't get as much attention is CHF, and just the getting referrals to that service, primarily because I think outcomes have been somewhat different depending on what places you go to. So from a cardiac rehab program phases, there's phase 1, which is post-surgery. You're in the hospital and your primary goal is to discharge and get home safely. So and that part of the programs hasn't really changed much in the last 20 years. It's ambulate, make sure that they can get up and get out of bed, get back into, climb stairs, and progress to phase 2. Phase 2 is what's probably had one of the most significant changes, and from our lens, really historically, high acuity patients really were the folks who went to cardiac rehab programs where they were high risk. They weren't sure what to do coming out of bypass surgery and so on and so forth. But over the last, I'd say even the last 10 years, maybe in 15 years or so, we've seen a larger spectrum of patients come in who are not just younger, but dealing with chronic disease issues that stem anywhere from sedentary lifestyles, high stress, and still having that present in the form of heart disease or MIs and heart attacks still. So the need for us to change the way cardiac rehab is presented has certainly changed over time. And then phase 3 is that third phase after the cardiac rehab program, is a continuation of exercise and lifestyle behavior changes. And so that's something that is not an insurance covered service, but is usually offered in most facilities that have a cardiac rehab program, and is a cash pay option for people to continue doing the same exercises or the same types of exercise that they were doing in phase 2.
Yeah, so to summarize, phase 1 happens in the hospital. Once you're discharged from the hospital, you have an opportunity to participate in phase 2, which is outpatient cardiac rehab. What we call cardiac rehab, and the clinic that we're talking about today is phase 2 cardiac rehab, and typically is covered by insurance. And then phase 3 is kind of whatever happens after phase 2, right? Which could be an organized program, could just be exercise on their own. So yeah, I appreciate that, Ashan. That's great. And
I have a quick question.
yeah.
So phase 2 is optional?
In a sense, yes. I think what we have advocated for most of our cardiologists is that we don't make it an optional thing, that we really, one, we see from an outcome standpoint, those who participate in cardiac rehab have over a 30% improvement in their risk of mortality. So it's kind of a no-brainer that you should go to cardiac rehab after an event, but it's not something that's a requirement by most cardiologists or programs.
I'll add to that, Jeff, just real quick, because there's some data on this, and it's a really important question you're asking, because the answer truly is no. Like, you can't force people to go to an outpatient service, right? And Ashan had mentioned the heart failure population, congestive heart failure, CHF, is there are people that get hospitalized after some kind of event for heart failure. And what we know is there's only about 3% of people with qualifying diagnoses with heart failure actually attend a cardiac rehab. So the referral numbers are low. I should say the attendance numbers are low, but the referral numbers are also low. And there's a number of reasons why that's the case. Availability of programs is certainly part of it. But then the known value of what cardiac rehab can do is another big part of it. So it is not... You can't force people to go to an outpatient program, but it is one of those things that is obviously highly recommended for people rehabilitating from a cardiac event or surgery.
I appreciate it. I did not know that, and I've just been enlightened.
Much so.
Alex, can you tell us a little bit about what it's like to work in a cardiac rehab clinic day to day?
Yeah, absolutely. For our clinic here at Valley Medical Center, we have 8 classes throughout the day. We see about 70 patients. Staffing wise, we've got 2 registered nurses and 3 exercise physiologists. We all have dedicated roles clearly defined for each class time, so we know where each person is and what they're doing each hour. From a patient standpoint, exercise is largely independent. They come in for their orientation. They do an exercise test, a graded exercise test, where we are estimating their max VO2 based off of their exercise plan and their cardiac risk level. We determine, what percentage of that VO2 should we exercise them, or at least initially start them at. They come in on their first exercise day. We do those intensities, make any adjustments if we need to. One-on-one with patients really comes down to where they're at in the program. Their first exercise day, yes, we're one-on-one. We're going to show them the ropes. A little bit later in the program, they will start resistance training, where they'll be one-on-one with an exercise physiologist or nurse using our biocircuit equipment to initially do 1 rep max testing. And again, having an exercise prescription based off of that 1 rep max. We use 6 different machines for that. The other one-on-one component is every 30 days, each patient has a individualized treatment plan or a progress review, where we reassess their initial submax levels, their grip strength, their waist measurement, their resting VO2. So we get that objective data throughout the program as a way of measuring that objective progress. Each patient is generally here for 36 visits. We're here Monday, Wednesday, Friday, so 3 times a week, and program takes about 12 weeks.
Yeah, you just opened up a can of worms, man. And I have a million questions. I actually don't know if I'll be able to get all those questions in, but and they really had to do with exercise prescription. But I'm going to hold off for a second and ask a question probably to both of you, because it sounds like starting about 2.5 years ago, your cardiac rehab department at Valley Medical Center started to undergo some significant shifts in practice. So could you tell me and the listeners a little bit about how this all started and what's different today compared to when this shift started?
Yeah. Maybe I'll go first and then you can add. I think even just alluding to some of the background for cardiac rehab, Jeff, patients used to be really high acuity, and that's all that cardiac rehab programs would see. And so from that lens, the goal really was around keeping people safe. And it was very nurse oriented and led, where everyone was on a telemetry monitor, and we would just ask, are you feeling okay? Are you feeling okay? How hard do you feel like you're working? And it was very subjective in nature from a program. So that over time has shifted. We've started to get people who are younger. We've started to get people who are less high risk. And so we're seeing a broader range of folks. And therefore, this need to actually produce outcomes that showed our program is really effective started to increase. And the desire for us to see people for the full 36 visits of the program is getting more important as well, because our reimbursement for that started to go down as well. So that's what stemmed some of the need for us to want to change, that we wanted to have people participate in the program for longer, but also to show that we're actually doing something that's really effective. And so as you were saying, what opens up a can of worms for you is we shifted from this RPE driven or subjective driven program where we have people come in and exercise based off of how they're feeling and just making sure we're safe, to a more of a exercise prescription approach where we base a lot of the decisions we make based off of a lot of the baseline testing. So submax tests we do a graded exercise test, which we estimate their VO2 from, and based off of that, we prescribe a percentage of their VO2 as what they're doing for their cardiovascular exercise. Same thing for strength training. Strength training in most cardiac rehab programs is very minimal, and we've done quite a big shift in making that a pretty significant component of the program. So I think those, to me, would be some of the big shifts that we've changed from being truly like a subjective to more of a like objective measures and testing. And then we're now seeing the outcomes and the results of that. Our patients are getting much healthier. We're seeing their improvement be much more significant. So I think a lot of those things have changed by some of these processes we've implemented. I don't know if you want to add anything, Alex.
A lot of what we used to do, kind of similar to what Sean said, is what has always been done. We started asking ourselves, can we do this more efficiently and more effectively? Can we deliver a more quality program? And a lot of times when we would ask ourselves, why do we do it this way? It was, well, that's the way it's always been done. So we would look at those processes and workflows in particular, and we're at a point now where we do things with a purpose. It is scientifically backed, and the outcomes show it.
Question I have, and I'm going to preface this by saying that all I'm really trying to do with this question is try to put myself in the clinic so I can get a better sense of, like, as though I'm actually there seeing what's happening. So you moved away from RPE and you're starting with 1 rep maxes, or in the case of aerobic programming, you're estimating VO2 max and using percentages of that. What, just focusing for a second on just resistance training, the patient slash client is now performing a set of something, whatever that is, a leg press, a row, a chest press, or something like that. Are they being taken to muscle failure? And if they're not being taken to muscle failure, then, because then subjectivity does come into play if they're not taken to muscle failure. So at that point, are you using rate of perceived effort or repetitions in reserve or something like that to guide intensity?
Do you guys mind if I jump in real quick?
Yeah.
Because I actually know exactly where Jeff's coming from with this and how this question is even, like, I know what you were asking right here, Jeff. And
Absolutely.
what Ashan and Alex were saying about RPE, the status quo in cardiac rehab for testing, like for reassessment, is based largely on RPE alone. So the prescription that is done is based purely on RPE for cardiovascular exercise. And what they still do as part of the submax testing, as part of prescription, like they're tracking RPE every day on every exercise that's performed. But the testing is what's changed from being RPE predominant to, we're going to perform a submax test that pushes you through these phases in this protocol to estimate a workload that we're going to have you start at. And then what Alex was saying too, I think, was, I said I wasn't going to do this, guys, and I did it anyways. Dang it! But then what Alex was alluding to was, we know that initial prescription based on either their estimated VO2 or their peak force production on the biocircuit, may be off a little bit. Like it may not either push them to the RPE level that we want or be a little bit too hard. And we adjust in those first few sessions after that initial prescription to do so. So sorry guys for jumping in. I just knew exactly what Jeff was asking
Oh,
from the
absolutely.
outset. So
Yeah, Thomas knows me inside and out when it comes to this stuff, so I appreciate that. Did you two have anything to add to that?
Yeah.
Go ahead.
Was I know some other changes that we didn't quite mention was, we've started using patients' personal heart rate monitors that get um, transmitted to TVs throughout the clinic. So they get that real-time feedback for how their body is responding to their exercise. That was something we didn't used to do. I think it drives engagement with exercise a little bit more. With the technology that we use, they can use that at home to track their exercises as well. So we get to see that feedback on, well, yes, you went for a walk at home, but were you working at an intensity that was beneficial, or was it, walking the dog and smelling the roses every couple of minutes? So
Right.
that's been a pretty significant change too, from a patient standpoint and program standpoint. That has been a good addition.
For sure.
And one other question I have regarding exercise prescription. And again, for now, I'm going to stick to resistance training. I might ask a question or two regarding aerobic training later on in the episode. Um, but I'm just curious, are the patients there long enough that you can start periodizing the resistance training in the sense of, you know, incorporating different repetition ranges? So maybe to be a little bit more clear with my question, for example, maybe starting them at 12 to 15 for a 3 or 4 week phase, and then dropping them to 10 to 12, and some sort of linear fashion, maybe to 8 to 10. But are they there long enough that you can span repetition ranges, or how do you go about that?
That's a really good question. So, in part, we prescribe exercise based off of their risk, and so when it really depends on when they end up starting with resistance training,
Gotcha.
and it allows us to probably get a phase and a half in by the time they've met the end of their 12 weeks. But it really gives us then the opportunity to have the conversation around the importance of why having a phase 3 and progressing into the additional phases of strength training is really important. So
Good.
so yes and no in some instances, but really it's around the conversation of how do we make this a long-term lifestyle than just a 12 weeks and you're done.
Perfect. Love it.
Yep.
Something that I've learned, Jeff, and this is like from my physical therapy lens that I think you'll appreciate. There are a lot of people that start cardiac rehab that need a pretty significant familiarization phase. Like that, it has been a long time since they've exercised before this, particularly resistance training. There are people that come into the program that have sternal precautions at times, and we prescribe differently for those people and have different, different start points for those folks that are going to start with pain. So, there's a lot of considerations that go into that, and I found that to be a really interesting element of this too.
Yeah, that's a good thing to point out because I don't work in cardiac rehab. I don't have experience with this. And with the populations that I've had experience training, the familiarization phase typically lasts 2, 3, and maybe 4 weeks. But I could totally imagine that this is a population where, well, there's going to be a lot of times where that's not the case at all. And you just kind of need to stay at a certain level for an extended period of time as compared to what I typically do. So that makes total sense.
Yeah. So, we've been talking about this for a bit now, and one of the specific changes, Alex and Ashan, that you guys had mentioned has happened over the last couple of years, is strength training integration. I'd love it actually if, as part of this question, you can kind of talk about what we were doing before, what Valley was doing before for resistance training, and what it looks like now. But I'll say this first. It seems obvious that cardiovascular exercise following a cardiac event would be important. And I think when most people picture cardiac rehab, they picture patients in a room doing cardio together. Why is resistance training important for this population early in their rehab? And again, then tell us kind of what that looks like.
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Are you a professional in the medical fitness industry? As a member of the Medical Fitness Association, you'll unlock exclusive networking opportunities with top experts in the field. Access cutting-edge education to stay ahead of industry trends and best practices. Don't miss out on the chance to advance your career. Join the Medical Fitness Association today. Visit medicalfitness.org to become a member. That's medicalfitness.org.
Yeah, first and foremost, increasing muscle mass. A lot of times when patients get to cardiac rehab, they've lost a lot of muscle, whether it was, they had a long hospital stay, they're on steroid precautions, they haven't been using those muscles. A lot of our patients are elderly and are dealing with osteoporosis, sarcopenia. Our goal is to increase that muscle mass. There are some studies out there showing that resistance training is also just as effective at reducing some cardiovascular risk and all-cause mortality, similar to aerobic training. But when combined with aerobic training, that benefit is even greater than just resistance training or aerobic training alone.
Yeah, and just to add on, like what it used to look like before, the old version of resistance training and cardiac rehab was an exercise specialist going and working one-on-one in a small space within our cardiac rehab space, and just taking them through some resistance bands and dumbbells that might, in most cases, is not actually doing anything to really stimulate muscle growth or breakdown. Is really just, can you get used to a movement? Can you get familiarized with doing something? And let's call that a form of resistance training. But in the sense of what we know and speak to when we talk about resistance training, it really wasn't there. And that itself took quite a large amount of time from the exercise specialist doing one-on-one care with that person. And that was a barrier for that being successful too. So we weren't even doing resistance training with everyone. It was just really those who we thought were going to be successful, or it might be easier to do it with them because of the nature of cardiac rehab. There's often 12 to 15 people in an hour in the program, and we can't necessarily have everyone do one-on-one training. So that's why we shifted, I think, to doing this style.
Yeah, Ashan, could you just expand a little bit on, like, so if it used to be dumbbells and bands, kind of what does that look like now?
Yeah, so now everyone goes through what we use as a Technogym's biocircuit. So it's a circuit style training that really does all the foundational movements. We have chest press, leg press, a pull down, leg extension, leg curl in a row. And it's on a timer. So it's 45 seconds of work, 30 seconds of rest. So for two reasons, it allows for us to be really efficient. We have up to 6 people going through the circuit at the same time, and it keeps people's heart rates elevated. So as Alex was mentioning, part of the benefit is getting both cardiovascular response, but also musculoskeletal endurance and breakdown. So with that happening, every patient does 2 rounds of that circuit and then comes back to the cardiac rehab space where they'll complete their session for the day. So that's it definitely helped with efficiency, and it also helped give people some meaningful resistance training as opposed to what it used to look like.
Yeah, this is right in my wheelhouse. This is something I'm very passionate about. You alluded to the underdosing that's so common, and just putting a weight in your hand or a resistance in your hand, whether it's in the form of a band or a lightweight, performing the movement, and then calling that resistance training when it needs to reach a certain level of effort and a certain proximity to muscle failure in order to elicit the adaptations like muscle, increasing lean muscle tissue strength or whatever the case may be. And I want to just make sure that the listeners understand how critical this is, because just because you're putting a resistance in, performing an exercise against resistance doesn't mean that it was actually a resistance training set. And a resistance training set, here's 4 people with a background in exercise science. So I'm preaching to the choir here. This is mostly for the listeners. to understand that a resistance training set in resistance training and strength training needs to be anaerobic. It's an anaerobic exercise. And so anaerobic by definition means that it is at or very near muscle failure, which leads to a question because this is cardiac rehab and you can't start with that. I would imagine that you aren't, that's the whole purpose of the familiarization phase. And it's,
Right.
I would imagine, I'm guessing here, but I would imagine that this is part of what determines, I'm sure along with many other things, the length of the familiarization phase, because you got to meet them at their capacity, and then you got to progress them and use your expertise and whatever other metrics you're using to determine. But that leads down to my question: how do you go about determining when it's appropriate to start pushing that person to either muscle failure or very near it? Again, I don't have experience in cardiac rehab, so this is really intriguing to me.
Yeah. Totally.
So our familiarization phase, on paper is about 4 weeks. Around that time frame, one of our staff members who, their role is biocircuit for the hour, they are down in the fitness center with the patients, um, discussing how that intensity feels, their compliance. The biocircuit gives them a compliance score on how well they have complied with the exercise prescription. And along with that, we use our expertise to then transition them into what we call as phase one. And the main difference is going to be eccentric overload. The machines will provide a 20% increase on that eccentric contraction, to continue building that strength.
Yeah. Okay. Great.
Maybe I might have heard the way you asked that question a little bit differently, Jeff. From a qualifying people into resistance training, we really try to get everyone to resistance training. And what Alex is talking about, everyone is stratified based off their risk. So based off of their initial cardiac diagnosis that they come into, they might have sternal precautions, and so usually in that case we have to wait about 10 weeks post their event to start with any sort of resistance training. But for most folks, well, after their first couple of weeks of just cardiac rehab, that we have determined that they don't have any other conditions that are exercise induced, or they aren't symptomatic, we try and get them into resistance training pretty quickly, because we know that this is a fairly short window of time that they're going to be in the program for. And so the earlier that we can start them just doing the practice and getting used to the fact that cardio and resistance training are both just as important for their overall health, the better. So that's and that kind of segued into what Alex was saying of the phases and things and how
Yeah,
that.
that's great. Yeah, I appreciate both of your responses, and yes, one of the things I was curious about was that safety aspect, and
Mhm.
how you build them up and know that it's going to be safe to take them to at or near muscle failure. So that was great. I have a follow-up question, something else, a little different subject, but it's something I'm very curious about, having worked in 4 different hospital systems, some private practices, working with clinicians across the spectrum of care. I'm curious, how did the referring physicians feel about the idea of integrating resistance training, and what did they want it to look like?
That's really interesting. We are pretty fortunate in the fact that our medical director is a cardiologist who is very pro, let's push our patients to their capabilities. And I think from that sense, he's given us a lot of leeway to say, I resistance training is important. We see the evidence that there is positive outcomes for these patients. And really, it has started with just the data that we've been able to pull in. What's unique about our program is we are able to capture all this data and report it back as our aggregate outcomes. So we show our cardiologist or any of our referring providers on an annual basis, these are the outcomes of our patients that have participated in the program for the past year. And so they're really bought in when it comes to the end results. Dr. Bush, our medical director and cardiologist, has really just been in support of let's be aggressive where we can and let's be conservative where we need to be. And so has given us that guidance and those bumpers. But for the most part, I think has been fairly I don't know what the right term might be, but has given us the leeway to kind of progress people as we felt was appropriate.
Love it. So glad to hear that.
Yeah, it's not always the case, but
No.
we're pretty lucky.
So generally speaking, guys, if you can think back to before the utilization of BioCircuit, you talked a lot about how that's been helpful as far as time and efficiency and ability to work with multiple people at the same time. But generally speaking, from a cardiac rehab perspective, what are the logistical challenges with providing resistance training in this setting?
Yeah, if you want to go first,
yeah, lack of equipment, space, lack of staffing for supervision to make sure that exercises are being done appropriately, correct technique, form. There's just a lack of a safety aspect for those patients. And so we found that, a lot of our patients just didn't get resistance training for those various reasons.
Well, and just a lack of education, understanding, what is resistance training? Why is it important? I'm a heart patient. Why am I supposed to be doing resistance training? And so just having a sense of value behind why I should be doing resistance training. There's almost some resistance that our yeses were met with at the initial onset of doing this type of stuff, because it didn't quite make sense, to our patients in their heads until they really understood, okay, this is how this is all connected with each other. So I think that was a big part of it too.
Well, a related question is, what about from like the exercise specialist standpoint and maybe early on the onboarding and early, because look, going back, if this was 30 years ago and I was just graduating with an undergrad and this was my first job or something like that, that would be a barrier. Just I would be a barrier a little bit because you'd have to get my confidence up and and all that stuff. So I'm just curious, is that something you're taking into consideration? Like, what does the onboarding process look like as it relates to this? And making sure that the exercise specialists are up to speed and have the confidence to engage in your protocols.
Yeah, I'd say so historically, and I can maybe speak to this as when I was in cardiac rehab, there's a pretty strong struggle between nursing and exercise, where nursing is really trying to keep our patients safe and they want to be, I would say, overly conservative in some instances. And then the exercise folks are really trying to push these people and be aggressive because we know what's going to get the outcome. And I think we are in a pretty unique situation in which the circuit system that we have is inherently safe. It's not just a stack of a series of dumbbells or a weight stack that we're having to work with. We have some built-in safety measures and protocols that are in place to make sure that we aren't injuring our patients or having them push beyond what their limitations are. There are some technologically advanced features of the system, as if I start going into true failure, it backs off on the weight a little bit, so I'm not actually injuring myself. So there's some of those things that have allowed for the other half of our team, the nursing side, to be like, okay, they can still do this, but be safe and effective, and then give the ESs, especially as new younger ESs who are coming into the program, feel like, okay, there's a process and standard procedure in place that they can follow, and we're just following the guidelines that are set in order for us to prescribe exercise. So it's not that people are being super creative and doing all kinds of wonky exercises. We're following a system that I think has built in a level of safety and comfort for our staff.
Yeah, that's great.
Yeah, I think that there was one thing I would add to this, because I know, Alex, you were just kind of in the last 6 months or so, we were bringing on a new exercise professional who came in as a newer graduate from a master's program and didn't have experience in the cardiac rehab setting. Very knowledgeable person at baseline, but new setting for him. And I think one of the big advantages is that, like, that 30-day individualized treatment plan process. At 30 days, we're going to reassess and check in with people and then follow the system, as Ashan was saying. So having that consistent check-in, These guys do daily checks that are, and I would say, the benefit to bringing someone in this setting, Jeff, is that it's a team setting. So no one is practicing on an island. Like Matt had the benefit of working alongside Alex for a while to see what the program process was and how he went about things and thought about things and made sure people were safe. Even during the time that Matt's been here, we've really started to push people into a new like cardio prescription of high intensity interval training when appropriate. So we have them do higher intervals for short periods and then back off and do lower intervals as part of their cardio. And that was a pretty new thing for everyone. But again, something that we agreed upon as a group and set about a strategy to perform. So there's a lot of structure that makes it a nice place for a new exercise specialist or professional to come in and do their work.
Alex and Ashan, one of the things I think about, especially as I hear what Thomas just said, I'm wrapping up a doctoral program in kinesiology. I'm pursuing an EDD. I got one more traditional class in my dissertation, and I'm done. And for the dissertation, it's not going to be traditional research. It's going to be something called action research. And my program is at Concordia University at St. Paul, Minnesota. It's an online asynchronous program, and they are pioneering action research in the field of kinesiology. So I had never heard of it, and that's the reason why. So in any case, the very short version, the reason why I'm bringing this up is because simplified, what action research is you kind of look at what do you determine, or how do you define success? So how do you define success? What is the pathway to success? What are the things that might be barriers or bottlenecks that you could potentially foresee on this pathway to success? And then because you obviously have to think about those things before you even get started. And then you develop a plan of action and you start moving towards what you have defined as the pathway to success. And then at some cadence, it could be once every 3 months, 6 months, a year, or whatever the case may be, at certain cadences, while you're collecting data, because that's another thing that you're doing is you're moving towards your pathway to success. You're collecting data, and then at certain cadences, you just stop and you reflect. And you see, am I still on this pathway to success? Am I still defining the success the same way? Maybe I'm going to redefine what success even is. Do I need to veer a little bit? Do I need to pivot completely? And all that stuff. So that's what action research is. And it applies not just to research, but to just building a successful business. And as Thomas was talking, that's what I was thinking about, because it sounds to me like you have really thought thoroughly about making sure, what are the potential friction points? What are the friction points? How are we going to address that? What is that pathway to success? You might not have looked at it the same way that I just described, but it sure seems like, or maybe you have, but it sure seems like that's what you're doing, and it's very impressive.
Yeah, I mean, to speak to that, I think one of our initial goals was how can we be really efficient? How can we be financially sustainable? And Josh Lyons, our CEO at Pinnacle, has for a long time felt like there needs to be a shift in the cardiac rehab space that delivers something that allows people to transition seamlessly into a long-term plan. And that was missing for a long time for us. And so we've kind of had that long-term vision in place as we've started to tackle these different milestones. And having the technology has certainly helped. Having the roles that Alex was mentioning has certainly helped. So it's a lot of these different pieces that we've put into place that has allowed us to sort of still to trend towards this end goal of having people in the program for longer, producing outcomes, and then transitioning into long-term plans. So I very much resonate with what you're saying from an action plan perspective.
All right, well, this is great, and I have maybe more than one more question for you, but I'll start with this one, because one of the other shifts that you mentioned was a focus on improving the patient's transition from phase two cardiac rehab, which is almost always covered by insurance, to phase three program, which essentially refers to the patient's ongoing exercise after participating in formal phase two cardiac rehab, as you had already mentioned. So tell us about why this transition is important, and what you have done to improve referrals in the phase three program at Valley Medical Center.
Well, it's important for a lot of reasons. I think primarily, one, we want to make sure that we're actually improving the health of these individuals and not just having them do 12 weeks and then just be done and then have them come back into cardiac rehab. That was actually an issue we were having for quite a long time, where people would come back every couple of years and back to cardiac rehab because they had another event. And it felt like we were just putting a band-aid on the situation and not actually addressing the root causes of some of these issues that they're dealing with from a lifestyle perspective. So that was one part of it, but also as a lifestyle medicine center here, we're focused on how do we make long-term change and make this really become a part of their lifestyle and behavior change. Um, so we reverse engineered from our Lifestyle 365 program, which we call is our phase 3 cardiac rehab program that really welcomes anyone, not just those who are dealing with cardiac issues, but anyone into the program, and reverse engineer cardiac rehab in a way that it really is succinct and fits. Right. So there's a very succinct and purposeful plan as people progress, just like we're talking about with resistance training, from a phase 1, 2, and then into a phase 3, where it makes obvious sense that this needs to be the next step, because I'm still getting the biofeedback from the heart rate monitoring system. I'm still a part of the resistance training protocol, and I know that there's more steps to go in this journey. And then if I do need support or I do need help, I'm in a place where I have the right professionals accessible to me to get feedback and and better support. So um, for us as a business, that's the way that we've always envisioned this business model working long term. Is let's have these different service lines be feeder groups into this phase 3 program that we can then be sustainable, make change, and implement in other locations as well. So I think from my lens, that's where I see that being where there being a lot of value into why we want to transition. And so that's where we started at and took some steps to make sure that the phase 2 cardiac rehab program feels really seamless to the phase 3 program that we offer.
Great.
Ashan, before we move on from that, because I actually think, if I was thinking about who our listeners are, I think they're probably people who want to receive referrals from the medical framework, right? Like they're people that they probably are prescribing exercise as exercise professionals, maybe in a health club, maybe in a large medical setting, maybe they're doing it on their own, right? But they'd love to see these patients. And I actually think there's something to learn from the work that you've done on the referral aspect in particular, like what happens at the end of the program to move people into that phase 3 program. Because I don't know, I think it is unique that we offer an exercise program that occurs after cardiac rehab, but I know we're not the only ones doing it. I think what is unique is that we've been pretty successful at getting people to make that transition. And I think it would be really helpful if you could share how you've done that.
Yeah, I think thanks for bringing that up, Thomas. Part of the transition phase that we've developed is to show patients how seamless the interaction can be from cardiac rehab to phase 3. And so we actually have our exercise specialists from the phase 3 program, the fitness center, come into the cardiac rehab space and complete the rest of what would be a progress review with the goal of joining 365. So our exercise specialist will do another strength test, body composition assessment, and then review what the patient's goals actually are, and then come up with a plan. It doesn't have to always be, let's join our program, but do you have a succinct plan in place that's going to help you continue to be on the track that you want to be on, and not just stop at the end of the 12 weeks? And so that has been what's allowed us to be, I think, really successful in doing that. We talk about long-term planning early in our phase of cardiac rehab, but also in what we call the vitality visit, let's actually work through the details of what is it that you're going to do, whether it's join this facility, or where if you're going to exercise at home, have you put a plan in place? Have you actually thought through the logistics of what that's going to look like, what that's going to be from an expense perspective? Are you going to get the same types of biofeedback from a 1RM or heart rate perspective that you would in this type of facility? And so it helps answer a lot of the unanswered questions that people sometimes just don't necessarily take the time to think about. How am I realistically going to do this? And so I think that's been really helpful for us to just to, as a cardiac rehab staff, knowing that people, regardless of if they join our phase 3 program or not, have a plan that they're walking away with. So I think that might be how I'd speak to it.
Yeah, absolutely.
Thomas, what I think about when I hear that is when you and I presented in San Antonio for the APTA combined section meeting, and how one of the themes, a major theme of our presentation, was passing the baton. And you're talking about passing the baton, but that there's literally all kinds of things that that baton represents
Mhm.
all kinds of things that you need to think about. So it's a nice, smooth transition. So again, I'm really impressed because you're passing the baton, but you're thinking about all the things, as opposed to the other thing that's typically happening, where the patient is being sent out into the abyss. Here's a home exercise program, or whatever the case may be, and that's what's the common, unfortunately, thing going on, whether it's orthopedic rehab, cardiac rehab, neurological rehab, etc. But you guys have really thought this out. You pass the baton, and everybody wins. So
Mhm.
I'm really glad, Thomas, that you asked that question. I love hearing it.
So the last question, I'll segue to something that Ashan had mentioned a little bit before, which is around program outcomes, excuse me. Part of the update to our cardiac rehab program a couple years ago was intended to support the collection of program outcomes data as part of the way that we practice. Could you guys summarize some of the key findings that we've been able to report about our patients' outcomes during this phase 2 program that we're calling BioBeats?
Yeah, absolutely. I think one of our main outcomes is VO2. The national average, or if I put it in terms of MET level, the national average for an increased MET level after completing cardiac rehab is about 1 to 1.5 METs. Our program has shown a 35.5% increase from baseline to program completion, which equates to about 2.3, 2.4 METs. So that's been a pretty significant increase in outcome for us. With grip strength, we've seen grip strength increase by about 12%, seen a reduction in resting blood pressure. And then as for waist measurement, which is the other outcome measure that we take, not too much of a significant change there, but as we start taking more data from our in-body, getting body composition analysis, muscle mass, body fat percentage, will be interesting to see how those numbers compare pre and post program.
Maybe to piggyback on that, from a program standpoint, the national average for participation in cardiac rehab is about 15 visits. So of the 36 visits that people are qualified for, nationally, only 15 visits are completed on average. And our program at our last interval check was on average, people are completing about 27 visits. So it's a significant improvement from the national average. That does include people who just make it to orientation, decide that they can't, for whatever logistical reasons or whatnot, they can't make it into the program. So it's rare that you'll see a 36 out of 36 perspective, but it's significant from our standpoint, and then turns into a financially viable program as well.
Here's a VO2 max question for you, since that's what we were just talking about. And again, this is just out of curiosity. Um, you guys are the experts here on this, and I'm not. So correct me if I'm wrong. But speaking absolutely, from an absolute standpoint, my understanding is that a capacity of 7 METs or below is not good. It's considered deconditioned, and that
Right.
10 METs, and it is going to depend on your biological sex, and it's going to depend on where you are, from an age what decade of life you're in. So I understand that as well. But generally speaking, my understanding is that 10 Mets is kind of a benchmark to shoot for, especially in your older years. And so with that as a background, is that something that you think about? Not only increasing how much you increase their aerobic capacity, but are you thinking about just their capacity in general and trying to make sure that they're above 7 Mets, for example, or reaching 10 or above 10?
Yeah, absolutely. Each individual has, a goal throughout their entire program to reach a certain Met level. We know that a lot of patients that come in with below average fitness capacity, their risk for all cause related mortality, having another cardiac event is very high. And so we are striving to get them into that next fitness category that reduces that risk of having another cardiovascular event, and decreasing that risk of all-cause mortality.
Okay.
I was trying so hard to bite my tongue on this, and I just these guys did a really good job of kicking it off. I just want to share, Jeff, we absolutely, certainly at a program level, think about it. And Alex, we've been working really hard on a paper that we're intending to submit for publication around the outcomes of this program. And one of the references we make is related to a 2018 article that was published largely by the Cleveland Clinic that looked at about 120,000 people overall and published what I think is largely accepted as the risk ranges for people post cardiac event. And we think constantly about, are we moving people out of that highest risk range? This was a retrospective study that they did, and looking back at these 120,000 people, the average age was around like mid 50s. They looked at men and women and established the norms for both. We're thinking pretty constantly about how can we get people out of that highest risk range. For people, again, average in their 50s, to live 10 more years, the likelihood of survival 10 more years jumps up significantly. Like people in this lower risk group, or the lowest group, the highest risk group, so the lowest VO2, highest risk group, have about a 79% chance of survival in 10 years from now. So if you're 55, 79% chance of living to 65. I don't feel good about that, right? If you move out of that, so jump up to above that 7 Mets that you're talking about, your survival probability jumps from 79% to 92%. And I know that I just said a lot of numbers, but it just maybe shows you that we are thinking about it an awful lot, and is something that we're constantly asking ourselves if we're meeting that standard, because it doesn't really matter. If we get people out of here and they don't make that improvement to a functional level that gives them a better chance to survive, it doesn't matter. So we have to be measuring whether we're getting people there. And I think it makes clear why both resistance training and cardiovascular training are important, because they both have unique and individual ways of helping people survive long term. So that was a really long way of answering that question, but I just wanted to chime in. So guys, I'd love it if, as we wrap up, anything that you want the listeners to know about, if they have questions, how to contact you, or where they can reach out to learn more about the work that you're doing?
From our lens, Pinnacle has our website that we do share information about the programs and services and contracting with individual locations. So that is a service that we run as Pinnacle, is to be able to help support the growth of these types of services at other locations. It's very much an opportunity that we see as a need for the country, of how we can optimize how cardiac rehab programs are run, just in general, but also into phase 3 programs. If you're interested or looking into how we can support phase 3 as well, our Pinnacle Medical Wellness.com is our website that you can visit, and or just even the valleymed.org /cardiac rehab is the local site here that gives you some good information around how we've run this program at this location too. So, and I'm sure Thomas, you'll share our contact information as well.
And I'll add that I'm the chair of the National Strength and Conditioning Association Special Populations Interest Group, and Thomas is on the executive council. And I guarantee you, with the community is on LinkedIn, and I guarantee you that I'm going to be sharing this podcast all over my social media, and it's going to include that group. You don't need to be certified through the NSCA or even a member of the NSCA to be part of this special interest group. And I'm going to follow up with an email to both of you and invite you to join, because you've got a lot of great stuff to share, and I would really appreciate it if on occasion you chimed in, shared, and because the world needs to hear what you're doing. So this was a great episode.
Absolutely. We'd love to, for sure.
All right, guys. Well, thanks so much for joining us today. It was an awesome conversation. Obviously, I have the privilege of seeing you guys weekly, sometimes daily, but I appreciate you taking some time to have this conversation with me on air with Jeff, and just sharing what you're doing. It's good work.
Yeah, thank you much for having us.
Yep.
Yeah, thanks so much. And I'll end it by saying that again, I sincerely believe that what you guys are doing just needs to be out there, on a national level. I really mean it. So I hope that somehow this can go viral, and because what you guys are doing is great. Really appreciated having you as guests on the show.
Absolutely.
Thank you very much.
Likewise, I think the work you guys are doing is helping the message get across there. So I appreciate it.
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.